Back to the plenary hall then for this morning's unmissable plenary on prostate cancer, where the debate today was whether genomic screening should be done before active surveillance.
Should more people remain on active surveillance? Or isn't it safe enough and should be less people on active surveillance? We have two challenging technologies which we will highlight in this session. The one is genetic profiling of tumors, and the other one is imaging with MRI.
It's an honor to have the opportunity to speak to you for a few minutes this morning about this evolving space of genomic testing for active surveillance, on which topic I would say I am pro-ish. We now have 3 tissue-based tests, Polaris, Oncotype, and Decipher. These all look at RNA in routinely archived paraffin-embedded tissue. There are multiple studies now out on each. All have been shown to improve in multivariable analyses the prediction of a variety of clinical outcomes: adverse pathology, recurrence after treatment, metastasis, and mortality. None of them, however, has yet been studied in the active surveillance setting. At some point, we will get to the point where genomics can clearly help us tailor surveillance protocols. We're not quite there yet. This is certainly not the end of the story. It's not even the beginning of the end, but it might be the end of the beginning.
Why MRI should help in this predicament? Because in patients treated by radical prostatectomy, it showed excellent sensitivity for detecting cancers with a grade group of at least 2. There's been recently a very thorough review of literature that has been published, and that review found 8 studies for a total of a bit less than 1,000 patients. 13% of the patients were reclassified by targeted and systematic biopsy. 11% by systematic biopsy alone, and 8% by targeted biopsy alone. So if we had not performed the MRI, we would have missed aggressive tumors in 8% of the patients.